Hi, I'm Mary Frances Luce. I'm a professor at the Fuqua School, obviously, in the marketing area. And I am interested in how people make decisions, how we all make decisions, in both our personal and professional lives. And I'm particularly interested in decisions that seem difficult or emotion laden or high stakes. And that has always caused me to have an interest in healthcare because healthcare decisions are often really tough ones, both from the professional side, the decisions docs have to make, for instance, and the personal side, of course, too. We're going to talk more about the professional side today. I'll be talking about value-based care for the next half hour or so. And most of you probably know this, but every Wednesday at 12:30, Fuqua faculty are coming to you via LinkedIn to talk about our research interests and what's happening out there. We'll end around 1 o'clock. I'll try to wrap up a good bit before one. We'll see, and I will definitely try to provide some time to answer your questions. So please put questions in the chat. And so, as I said, I'm ready to get going now. We'll start talking about value-based care, making it valuable, or really the challenges of implementing value-based care. That's really the kind of lens here. And the challenge, this is a nerdy way to start, but I am an academic, so I think I get to do that. The challenge is really that the problem of moving any kind of hospital or any other healthcare system, the challenge of moving it towards value-based care, which I'll define a little bit better in a minute, comes because we have to get into compensation systems for provider systems, and the problem it becomes or is very interdisciplinary. That's the nerdy part. It's interdisciplinary. What do I mean by that? Well, to really get this right, we have to understand economics, we have to understand psychology, and we have to have really good analytics. And let me just say another few words about that. What do I mean by this? Well, if we're moving towards value-based care, towards incentive systems that promote, overall health being provided as economically feasibly as possible, we need to set incentives. We need to use economic theory to set incentives to align goals. And those are very difficult problems, but many of them have been solved from the economic theory perspective. But we also have to layer in or understand psychology, understanding individual reactions to compensation systems, or really even more of a challenge to changes in compensation systems. And analytics really help us close the gap. We often see a gap between what economics tells us is the elegant solution and what psychology tells us people will accept, or how psychology tells us people will actually behave. It's a really interesting gap in general, especially if you're an academic. But it's also a challenging gap that we are starting to close, or that healthcare systems are starting to close, with analytics. And there's a little link here. This is a plug to our MSQM programs. We have a relatively new suite of programs that are mostly online that address these issues as well as others. I teach a value-based care class within our MSQM Health Analytics program, and there's a little link if you want to learn more. This is obviously, not a whole class in half an hour, but, a few of the themes that we really unpack. Okay, so to be concrete and quick, efficient today, I'm going to drill down to like one particular example and really compare two incentive systems that we can think of as like ends of a continuum. So what I'm really going to compare today is fee for service versus capitation. This isn't the same thing as value-based care, but most value-based care incentive systems push provider compensation towards capitation, away from fee for service. Many of you probably know what I did. Many of you know what I just said. I'm sure a few of you are probably still confused because I'm using, jargony terms. So let me explain it with one example. So imagine something such as a possible knee replacement, or imagine a patient with, an arthritic knee. So the standard way in the US, the standard way, dial back 10, 20 years, the standard way to compensate providers was through fee for service. So episodic payments tied to specific procedures. So somebody has a lot of knee pain, they finally need knee surgery, they go in, they get the surgery, the anesthesiologist gets paid something, the surgeon gets paid something for the surgery, maybe a few somethings, but everybody gets paid for the work they perform. Fee for service, episodic payments are tied to these actions. So that's kind of the old world in America, at least, for most healthcare. And as we move towards value-based care, one of the things that often happens is we move towards more of a capitated payment system. So with capitation, some organization, let's say, a health provider organization, a big one, Kaiser in California, or it could be eventually a small one. Some organization has a steady payment stream from each covered life, from each individual covered. And that steady payment stream, usually monthly, will happen no matter what the covered individuals need. And so then if one covered individual needs a knee replacement, the healthcare organization, takes all of the money it's been getting, sort of for that individual or for all the individuals. It has a pot of money, and the healthcare organization says, oh, this particular individual needs a knee replacement. We're going to pay for it. We have to pay for it. So with capitation, you have steady payments that are disconnected from both procedures and illnesses. And so what I'm going to do, again, is conceptualize these as kind of two ends of a continuum. And then, for the next 20 minutes or so, I want to talk about what really happens as we move systems or providers or groups from fee-for-service towards or to capitation. Okay. So first of all, why would we do such a thing? Well, there's a lot of great economic reasons to do this. So there's some advantages or goals of capitation. First of all, it makes the provider really free to act in a much more flexible way. Providers should like this. It makes the provider free to do whatever this expert person or group, I'm going to talk about it like it's a person, but it's usually a group, really. Whatever these experts think is best. So instead of, again, with the knee replacement, instead of it being the situation that, well, a surgeon's office can only really generate reimbursement and pay for doing surgery, so they have no incentive to say, let's try physical therapy. With capitation, the provider system, has the whole pot of money, and then they're free to say, well, let's try physical therapy first. It's less invasive, it's cheaper, and then, we'll keep surgery as the last resort. Okay. So that's kind of the carrot in a way. The next one, which is related, the next point is kind of the stick. And what I mean by that is the provider is also supposed to be, and probably usually is, motivated by being at risk from wasted health resources, or from waste of health resources. So if an unnecessary surgery is done under capitation, the provider group has to pay for that unnecessary surgery. It's the provider group's problem, not the, in the old fee-for-service system, it was really the insurer's fault, or the insurer's problem if there was an unnecessary surgery, because the surgeon still got paid. Okay. And then the provider also becomes responsible for overall health. A really strict capitation system will require the provider in charge of that capitation, whatever group that is, to say what is the overall best way to promote individual and population health, because they're flexible. And so again, you see things like the system then can shuttle folks towards, let's say physical therapy versus surgery based on what provides the best healthcare value. There's a lot of great examples of this. For example, Dartmouth's spine center is moving, or is a pioneer in moving towards these kinds of overall approaches. Okay, so overall, capitation essentially is really putting more power and decision rights into the provider's hands. And it's the theoretical goal is the this system allows essentially market forces to work a little bit better within the provider systems, and the expert providers can pick the best care, and they'll make the trade-offs about, where they should spend money. And so there's lots of good reasons to move this way. Lots of systems are moving this way. Lots of systems are already there. But there's some real challenges, and I want to just mention 3 challenges today. So the rest of the presentation is going through 3 challenges. One is we as individuals have a bias towards ignoring omissions and paying attention to actions. So once you shift the frame of reference for the providers, you may shift how they think about the need for care. 2, as individuals, we're risk averse. We don't like being at risk. And 3, as individuals, we have desire for individual control. So these are 3 robust psychological findings that create challenges, implementation challenges, as we try to move provider systems from fee-for-service towards capitation. And there's some of the answers to the questions that are often out there in terms of, why is it so hard to change compensation? Why do these things that seem to work so well on paper, and it seems like everybody's going to be better off, and it's going to be, monetarily, and there's going to be more health? Why are there so many challenges in the change, in the implementation? So these next 3 points help unpack why. Okay, so first of all, I want to talk a little bit about this bias towards omissions. So the idea is, we only have so many hours in a day, and most providers can't do everything that's beneficial, right? They have to make trade-offs with their own time. They have to make trade-offs with money. And what fee-for-service does is focus attention on procedures. Does this procedure make sense? Does this procedure make sense? Whereas capitation allows for a broader view. The provider is supposed to step back and say, overall, what is needed? But we have this interesting problem, and it's a pervasive issue when we shift the frame like this. And here's where this first part of the problem comes from. As individuals, we're essentially wired to focus on actions over omissions. And there's some good reasons for that I won't go into, but we look at our own actions and we can be very self-critical about our own actions. We don't tend to look at our own omissions. So if you think about a simple example of that might be, if we give money to a particular charity every year, and one year, maybe we're a little tight on cash and we think about ending it. If we think about ending that donation as our own action, right? It's default, it's happening, now I have to act to end it. We're going to tend to be really critical of ourselves and think, do I really need the money? Can't I give it to that good cause? Maybe feel some guilt. But there's lots of money we could be giving to charity that we don't think about. If those other instances are omissions, we're not acting, we're not doing anything, we're going to tend to be less self-critical, have less guilt, etc. Okay, so what does this have to do with physicians? Well, what's interesting here, and it's subtle, but it's a pervasive frame. What's interesting here is with fee-for-service, you're really focused on very concrete, specific actions for the providers. The surgeon is cutting. The physical therapist is, stretching, giving physical therapy. Didn't have a good parallel way to say that. But of course, providers focused on those actions will think, will know they're responsible for unnecessary procedures. They're not going to want to do them. And so we worry about fee-for-service in terms of ignoring alternatives to the procedures, other things that could be omitted, physical therapy instead of surgery for a surgeon can contribute to overtreatment. We get too many procedures because each physician is focused only on their own procedure. And they're likely to ask themselves a question such as, is this beneficial at all? Not because that's the action they're focused on. Not the question of, is there something else out there that might be better? With capitation, physicians, the provider organizations, they're responsible for overall care, which is great, but any care that's foregone now is an omission, right? The steady state becomes being paid for no action, as opposed to being paid when you act, being paid for no action. So every action is a change. Everything you neglect is an omission, and we tend to be easier on ourselves and even think less about omissions. And so that's why with capitation we worry about, and we tend to see the threat of undertreatment. And this is really well known from an economic perspective, but I think what often gets missed in the discussion is when you see undertreatment with capitation, yeah, maybe some of it's, greed or self-interest in that physician groups are saying, no, can't afford that. We want a better bonus. But I think a lot of it, and the reason the problem becomes so pervasive, is you've just shifted the frame so that no one's responsible for the healthcare actions. No action is an omission, and we're not as hard on ourselves about those. So what do we do about this? The problem is capitation shifts the bias from overtreatment with fee-for-service actions towards undertreatment, what happens when treatments are omissions. This may even contribute to disparities. I don't have a lot of time to really unpack that, but if the way to get treatment in a capitation system is through patient advocacy, through saying, I really need this procedure, or my mom really needs this procedure, some patient groups may be uniquely disadvantaged in that situation. And so we really worry about this issue of undertreatment with capitation. So what's the solution? Well, the solution we tend to see is some series of process measures. What I mean, process measures are just some sort of specific measures that are used to track and evaluate providers, such as X% of your covered women over this particular age need to have an annual or biannual mammogram, something like that. These process measures often provide early warning signs for omissions, that there's no system set up for cancer screening because nobody's really thinking about that as the action that they're responsible for. The process measure can create a trigger, an early warning sign that that's a problem. What this does is it erodes some of the capitation incentive system's flexibility, right? First, you tell the physician groups they're in charge of all care, and then you say, but you have to do X, Y, Z, A, B, C, and this other thing every Tuesday. And so there's this continual dance between really having the benefits of the freedom of capitation and then also ensuring that we don't have problematic undertreatment. And so this is where these systems often get very unwieldy and difficult. Really requires evidence-based IT. If you are going to require physician groups or provider groups to engage in certain specific activities, you want to really hope those activities are beneficial. All right. Next one is risk aversion, kind of related. So health outcomes aren't standardized, right? Because people aren't standardized. And so this is going to become very important to providers when we shift the financial risk from healthcare. So again, as I've mentioned, with fee-for-service, the provider's really only at risk or only in charge of, and so only at risk for their own effort during procedures. They might, do a procedure that isn't reimbursed, and that stinks, but that's all they're really at risk for, their own costs, time, people they pay, nurses, physician assistants, et cetera, for their procedures. With capitation, the provider is at risk for patient health outcomes. Now, this is a feature, not a bug in this system, because the idea is if your patients have poor health outcomes, you're going to pay more. We're motivating you, the provider, to really want to maximize health. But as individuals, none of us, maybe a few of us, but most of us, are risk averse in compensation. We don't like risk. We like to know, what our outcomes are going to be. We like to pay our mortgages. We don't like to be at much risk. We have a lot of resistance to that. Now, with fee-for-service, providers really can only control their risk by making sure that they do procedures that the insurance company will approve, and that's a pretty capped risk. With capitation, the most obvious way and the biggest way usually to control risk is by picking your patients, avoiding patients that won't hit benchmarks or, for cost, or won't hit benchmarks for quality if you're worried about process measures. And so that's a really serious problem with capitation. This is a very well-known problem, that there's massive incentives to select healthier, more adherent patients, or at least patients you perceive to be that way. This has obvious implications for health disparities, right? You can guess the kinds of patients that are likely to have poor outcomes. Not all, but many of them are in vulnerable groups or disadvantaged groups. And so we really want to worry about that. How do we fix this? What's the solution? We have to level the playing field across patients with risk adjustment models. We need really good risk adjustment models in capitation payments. And if that's not hard enough, and that requires a lot of good IT, we also have to explain them well enough, these risk adjustment models, so that providers believe that risk is appropriately adjusted. So this requires some really deep clinical knowledge applied to outcome prediction. All right. Third point is another feature of the capitation system that becomes challenging in practice. So health is a team sport. So health is multiply determined by all sorts of provider teams, whether they're an actual team working together or whether they're just the sort of virtual, if you will, team for one patient. So if I get, one drug from a specialist and a different drug from my primary care provider, and those drugs interact, I can have a bad outcome. Obviously, we have health records to try to take care of all that, but capitation is really trying to push towards a wider integrated team view, right? The surgeon recommends physical therapy first because it's better for the patient and cheaper if it works. And the surgeon doesn't feel like they're losing money because they're getting an income flow that's independent of anybody's particular surgery. Now, that's great. That's what we want to have happen. But again, as individuals, we tend to have a bias towards controlling things, towards controllability, particularly, again, for incentive systems, right? Nobody likes their own incentives, their own income to be based on other people's actions. And so once you move towards a more of a team view, right, there's one payment per month per patient, and all of their healthcare needs to be coordinated for that patient, you tend to lose controllability as an individual. And so then you can tend to get into issues. So what happens? Well, each provider needs to rely on other providers. And we also tend to have a bias towards thinking our own behavior is a little more positive than on average we think everybody else's is, because we know the reasons for our own behavior and we always think they're good, or we wouldn't be doing most of the things we do. So this is a system where you can, or an issue where you can end up with a lot of resistance or dissatisfaction from provider groups, because once it starts to become clear that outcomes are based on everybody's actions, when there's a negative event or a big cost, there's really a tendency to kind of point fingers and think, well, as an individual provider, I don't like this system so much because I know I can do, what I need to do well, but these other people are messing it up for me. So what we tend to see this issue pushing towards is, again, IT solutions to track team member contributions. So we tend to see, because of this issue, more and more pressure on electronic health records, not just to track the patient, but to track the other providers too, to really see who's doing what and when, are things being done in a way they should be done. And so that at least there's some confidence that if there are financial or health outcomes that don't seem optimal, we can go back and kind of get to the cause of the problem and fix our systems. Again, needs to be evidence-based, right? You can't just write down everything everybody wants to do or is doing. You want to have a kind of a bias towards, well, what should be done in these situations, and let's make sure that the needed actions are getting picked up. By the way, one last point here, this is a place, better health records and more health records that promote integration. This is a place where we see the push towards value-based care really helping spur innovation, and not innovation in terms of like new drugs and new devices, but innovation in terms of how should these systems work together so that we can really maximize health. And this is kind of an important hidden benefit of some of the moves we see in incentive systems. All right. So overall, I talked about 3 solutions today. They all really boil down to analytics. We want to make sure that there's some system, something systematic in place first that allows to flag for someone when beneficial actions are being omitted. We need risk adjustment, or we really can't get more flexible in payment. And we want great electronic health records, and also often there's decision aids built in. Didn't really talk about that, for encouraging coordination and integration. And so we really need innovative analytical professionals in this space. I put the link for the MSQM Health Analytics program we have up again, because we've got some really interesting people in that program, students, really interesting content, and this program is where Fuqua is absolutely on the edge of pushing analytics, into business, and in particular into the business of healthcare. All right, just a few minutes left for questions, but thank you. I hope I didn't talk too fast. Half an hour is pretty quick. As I'm waiting to see if I get questions in the chat, I'll mention a couple of things. One question I often get is like, where's bundled care in all of this? So a common step is between fee-for-service and capitation. A common step is often bundled payments or bundled care. And so what that would be, for instance, is there's one reimbursement amount for an overall knee replacement. So we bundle together the anesthesia, maybe even some of the physical therapy afterwards, the nursing, the physician, the surgeon, blah, 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 put it all together, and there's one, big payment. And so that functions almost like capitation does, is in that the provider group gets a chunk of money, and then they're responsible for providing the best needed care, out of that money. But it's not by, individuals, it's by one episode. So it's kind of, when I was saying before that fee for service to capitation, you can think of it like a continuum. You can think about bundled payments as something in the middle of that continuum. Shared savings, same thing, if you're interested in that. All right. Not seeing questions. Thank you, guys. Too bad I can't see your faces. I'm glad that I had this opportunity to be part of LinkedIn Live. And thank you so much for joining us. So next week at the same time, same virtual place, Professor Aaron Kay from our management area will talk about some recent research that finds how military veterans are perceived both by employers and the public. And please, again, follow Fuqua, on LinkedIn. I wanted to say follow LinkedIn Live, but follow Fuqua on LinkedIn to be alerted to these LinkedIn Live events and other events. Thank you very much.